Hi, folks. We're going to do a whirlwind tour of the allergy and hypersensitivity lecture for a review before your exam. So at the most basic level, hypersensitivity is an injurious or pathologic immune reaction. It can be triggered by foreign antigen types, or it can be triggered by self-antigens, which we refer to as autoimmune disease, and which I'll cover next. For the first lecture, we largely talked about type 1, which is also known as allergic hypersensitivity. And the basics here are that IgE antibodies and mast cell effector molecules lead to these allergic type responses. Ultimately, this causes rapid vascular leakage and mucosal secretions, inflammation, which we all associate with allergic responses. What do these look like in terms of mechanism? Well, we have IgE antibodies being secreted here by a plasma cell. Those IgE antibodies can bind the Fc epsilon receptor on some effector cells like basophils in this example. That activates the basophils, and they can then produce cytokines and other effector molecules, which basically kick off the allergic response. Same type of thing happens for mast cells, which get activated by a similar mechanism and causes release of different granules. These granules you can think of as having multiple classes of different effector products. Some really common ones are tryptase, histamine, a bunch of different cytokines, prostaglandins, and leukotrienes. And so you can imagine that a lot of these are also targets for treatment of allergic type responses. So we talked about different kinds of treatments. Of course, avoidance is the best treatment when it comes to allergic type responses, but in the event that somebody is exposed to their allergen, in the case of an anaphylactic type response, epinephrine might be recommended. Often antihistamines are given for less serious type of responses, sometimes oral steroids, but that's still kind of questionable and depends on the individual and the treatment needed. We had a brief chat about oral immunotherapy as a new strategy to overcome allergic type responses. And the reason why this is promising is because people think that allergies start because of exposure that happens through the skin, and that is more likely to lead to an allergic type response, whereas oral exposure early in life is more likely to give you tolerance and less likely to give you an allergic type response. We talked about some ways to kind of induce that type of tolerance. One way to do that is oral immunotherapy, basically where patients are repetitively exposed to escalating doses of their allergen over the course of many months. Of course, this can have lots of different side effects. Anaphylaxis in the worst case can also lead to abdominal pain and some of the other symptoms that we would associate with allergic type responses of a less serious nature. And so there's a lot of dropout from this. But the idea is that perhaps we could combine oral immunotherapy with other treatments, other biologicals. So things like anti-IgE, so reducing those IgE antibodies so that you get less of the effector responses, or with cytokines or anti-cytokine responses to reduce the associated allergic cytokine response. We briefly talked about allergic rhinitis, which is very common in the US population. Treatment options will include things like oral antihistamines, saline rinses to try to get rid of the pollens, nasal steroid sprays, and potentially allergy shots. We finished the lecture by talking briefly by introducing these different types of hypersensitivity reactions. So even though this nomenclature is not really popular at this point in terms of the scientific edge of understanding allergic responses, it is important for general classifications, and it's very common on standardized tests. So we just talked about type 1 immediate responses. These are your classic immediate allergic responses with the IgE antibodies. We talked briefly about type 2 responses, which tend to be interactions of antibodies with a cell surface antigen or an extracellular matrix protein. We talked about type 3 responses, which are immune complexes, in other words, antibodies that are bound with soluble or circulating antigens. And then we talked about type 4 responses, which tend to be T cell mediated. So we discussed some examples, but overall, this type of hypersensitivity response tends to be more on the autoimmune side. So I'll cover that in the next section. Type 3 responses, we did talk about some examples that would not be considered autoimmune. So for example, if you inject a foreign protein like a horse antitoxin, which people have used for treatments for other diseases, that can lead to an antibody response against those horse proteins that can develop over the course of a week or so. And ultimately, what that means is that you're making immune complexes. So your human antibodies are binding to those foreign proteins and kind of gumming up together. And when that happens, these complexes can deposit in some of the delicate blood vessels. So you get symptoms like vasculitis, nephritis, and arthritis. And once those foreign proteins clear from your body, the symptoms tend to go away. This is particularly relevant when it comes to antivenin manufacturing or antivenoms. So recall that they collect the venoms from the snakes. They then use that to make a reference venom, which is then repeatedly injected into an animal. Typically, it's horses. And then that horse serum is collected, which has the antibodies against the venom. And eventually, that's given to a patient who might have been exposed. For example, has been envenomated by a coral snake, as shown here. And that's where you can get immune complexes forming in everyday treatments. So finally, we talked about type 4 hypersensitivities, that there are lots of different examples of this. One of the examples that we talked about was delayed type hypersensitivity. So when you're thinking about type 4 responses, think of the example of poison ivy, because this is basically where there's a protein that acts as a hapten. So it's covalently binding to and modifying your proteins and altering their structures. And ultimately, that makes them pretty immunogenic to your T cells. And so you get Th1 cell activation. Remember, these are the inflammatory activating type cells. And ultimately, that can recruit other cells to the response. And so you get these delayed type hypersensitivity reactions on skin that look like different rashes and bubbles and boils. You might see also skin redness or discoloration, some itching associated with the response. So classic inflammation signs, swelling, bumps, blisters, hot or tender skin. I'll just conclude by reminding you that the drugs to treat allergy tend to be palliative. So really it's just about counteracting symptoms that are already happening. So we talked about those at the beginning, but I'll reiterate: antihistamines, leukotriene receptor blockers, corticosteroids, anti-IgE antibodies. These are all very common for treatment of allergic responses. So we will stop there, and I will see you in a minute for the autoimmune summary lectures.